You are listening to another Discovering New Horizons podcast featuring Dr. Jim Polakof. Today's focus is on back pain, and Dr. Jim's guest is Dr. Gabriel Smith from Duke Spine and Pain Management. As always, each podcast episode is a search for the truth and how it applies to our daily lives and well-being. Now, here to take you on this exciting New Horizons journey is our host, Dr. Jim Polakof.
Oh, my aching back. How often have you heard that expression before? Well, there's a good reason for it. Some 65 million Americans suffer from back pain every so often or sometimes regularly. And 16 million Americans have chronic back pain, meaning they hurt every day. Now, you can only take so much Aleve, Motrin, Advil, and after a while, it's going to do damage to your system. And of course, you can try physical therapy. Sometimes it works, but sometimes it doesn't. So what happens when you have that constant back pain? Well, at that point, you're probably going to want to see a pain management specialist. So we're fortunate today that I have Dr. Gabriel Smith, who is a board-certified pain management specialist and a physiatrist. Now, Dr. Smith is part of the renowned Duke Spine and Pain Management in Raleigh, North Carolina, an assistant professor of neurology at Duke. So we're very fortunate. So welcome, Dr. Smith. It's good to have you with us.
Thank you so much for having me. This is a great opportunity.
Well, I'm glad. It's a great opportunity for us as well. Now, I'd like to begin by enlightening our listeners a bit. Let's face it. I mean, people with back pain, whether it's occasional or whether it's chronic, they're tried everything. I mean, they've tried stretching. They go to the medicine cabinet and pick out an Advil or an Aleve or a Motrin. They try physical therapy, which sometimes works and sometimes it doesn't. They try everything.
Yeah.
But when is it time that a person should know it's time to reach out to a pain management specialist such as yourself? When is the accurate time to do that?
I think that is the critical question. Ultimately, when you look at someone who has, for example, an acute back pain flare-up, just a 45-year-old gentleman, no prior history of back pain, who has a flare-up, even a significant flare-up of back pain. There have been wide studies that have looked at that type of a scenario that essentially within 30 days, about 90% of those people are going to be better, even without doing anything very substantial, maybe some over-the-counter meds, maybe a little bit of stretching, maybe a little bit of resting and things like that. Although, 30, 40, 50 years ago, for things like back pain or sciatica, strict bed rest was sort of the recommended course. That's not really the course, right? Being as active as you can be is actually better for those situations. But I think getting to your point, once you're past that 4 or 5 week mark, if things are, if you're still struggling, most people, like I would say, most people could benefit from starting off with their primary care physician and seeing if something that may be a prescription medication, but maybe something like a muscle relaxer or steroid dose pack or things like that could be a first line. But your question, again, gets to the point of, okay, what if you've tried those basic things and people are still struggling?
And they don't work, exactly.
Exactly. So that's the point, I think, when seeing someone who's board certified in pain management is a reasonable next step. And, we can talk a little bit about sort of the way I think about treatment. And we could just now, or if that plays into another question you have down the line, that's okay too.
Well, of course, let's talk about what you specialize in and, excuse me, the right time to see someone like yourself. But let's talk about spinal issues. You obviously treat spinal issues, joint and nerve pain, obviously. I think you address that as well.
Sure.
What do you address, and when did this get to the point where you tell a patient, I'm sorry, this is all I can do, and I think you're going to have surgery?
Yeah, so that kind of plays right into the way I think about treatment for pain in general, I think about it in terms of categories of treatment. Okay, you can think about it like buckets, so to speak. You got non-procedural care and you've got procedural care. And in the procedural care, you have things that are minimally invasive, like the things that I would do or other pain specialists would do, injection therapy, other things like that. And then, of course, surgery is kind of in that bucket. But outside of those interventional things, I think about medications, physical therapy, other kind of what I would call modalities. And in that, I include things, the basic stuff: ice, heat, a TENS unit, massage, even other categories of kind of more alternative medicine.
Mm-hmm. Acupuncture,
chiropractic. If you can sort of at least think about these things in categories, it makes the treatment plan for each individual a little bit more organized. And then you can also have that discussion with folks about, there are people who are very averse to doing any type of procedural care whatsoever. And that's okay. That's an individual's choice. And once you have a sense of what they are willing to do or willing to try, you can really kind of focus more on those different categories of treatment.
So obviously you don't try to force something down a patient's throat. You basically give them some options, and they can more or less pick and choose what they're comfortable with. Now, you mentioned injections. Obviously, that's one of the key things I know that you do. Can you describe what these injections are all about? In other words, the type of substance that goes into a body and how you go ahead and perform the injections. Can you give us some idea about how that all works?
Absolutely. So the way I think about the procedural care that I do, I think about it in terms of kind of what type of image guidance is appropriate for whatever procedure I'm doing. Most of the time when I'm doing a nerve block, for example, or a joint injection or a soft tissue injection, and that would include muscles, tendons, things like that, I prefer to use ultrasound. Because with an ultrasound machine, you can see all of those soft tissue structures. And for listeners who may not have ever seen an ultrasound, for example, of a nerve or things like that, the image has almost the same quality or the same specificity as like an MRI. Mm-hmm. Whereas the fluoroscopy, which is basically the X-ray, I use that for anytime I'm doing any type of spinal procedure, because it gives a much better picture of the bones, the joints, and some of those landmarks that are critical for spinal procedures that you just can't see as well with an ultrasound.
So what do you inject into the body as far as when you do the injections? What's the substance that actually goes into someone's body?
Most of the time, it's a combination of a local anesthetic like lidocaine and sometimes bupivacaine, which is a little bit longer acting local anesthetic, and typically a steroid. And there's different choices of steroid, but most of the time when I'm doing a steroid injection, I'll use a medicine called dexamethasone. And I'm more comfortable with that preparation because it is what's called a non-particulate steroid. In other words, it doesn't have particles in it. It's not, milky white like you would expect a kind of a cortisone type or another version, Kenalog type of preparation. Dexamethasone is clear like water. There's no particles in it. And in that sense, I feel like it has a little bit of a better safety profile. When you think about possibility, for example, of uptake in the vascular system of whatever injectate is being injected, I would rather use something that we know is safe intravascularly than something that could cause problems, like a particulate steroid. So to answer your question, it's pretty much a local anesthetic and a steroid most of the time. There are certain exceptions where I won't use a steroid at all, either because it's not indicated. For example, when I'm doing diagnostic joint injections, where I will basically be numbing up the joints of the spine to see, is that the problem? You don't really need a steroid for that. That's not the purpose. And so I won't include a steroid in those injections.
So you really do hone it into the individual needs. It's just not a catch-all, here, we'll put something into the needle and shove it in. You actually, based on the patient's specific needs, that's how you decide what you're going to inject.
Yeah.
People are sometimes afraid of needles. Does it hurt?
It can. We have different ways to sort of mitigate that. For one thing, I will use what's called a small gauge needle. That's how we term the thickness of the needle. I typically will use a 27 gauge needle, which is very, very thin. I mean, thinner than a mechanical pencil lead, and that is the initial lidocaine that I will numb up the skin, the area that I'm actually going to end up putting the kind of second injection into.
So the person's back at that point is numb, and then when you actually go ahead and obviously use a different needle for the injection itself, there's really not a lot of pain attached to it.
That's right. At that point, it's usually more pressure than pain.
So tell me this: someone you inject. What is the normal time in terms of how soon do they start to feel relief? And then how long does the relief last?
That too is kind of dependent on the type of injection we're doing. And I think to some degree, the type of medicine we're using. So to get back to my example about, when I see someone with low back pain, for example, and it's really pointing to the fact that the joints are causing the pain, or at least that's what it seems like. And we do a purely diagnostic injection with just lidocaine. That type of thing, we can see relief pretty much immediately, but we don't necessarily expect that relief to last a very long time. And it doesn't need to last a very long time to give us the information that we need. On the other hand, there's other type of injections, for example, epidural injections. So for people who have sciatica or other things like that, where in those situations, it really is preferable to use a steroid preparation, because the purpose with that is to help with inflammation and help with the pain more for a longer term, not so much just for a diagnostic purpose. And that can be months, years, it can be days. I mean, sometimes it's hard to know.
So it really depends on the individual. Everyone is different, and hopefully someone gets immediate relief and it lasts for a while, and sometimes it doesn't always work out that way. But I suppose if the pain continues even after the injections that you've discussed, I understand that, like for chronic pain, as an example, there's a spinal cord stimulator that you utilize. Can you tell us about that?
Absolutely. So a spinal cord stimulator is basically a device where it's really unique in medicine in terms of the way that we're able to use a stimulator device as a trial run first, and then depending on the results of the trial run, determine if that's a good treatment option for the long term for an individual. It is a non-surgical procedure. It is very similar to an injection. I mean, in terms of the patient experience, it's
is this really the trial you're talking about now?
It's the trial. The
okay. To see if it works or not.
Yeah. So let me just give you like a brief case of someone I just did one on. I just did one on Monday. I did 3 on Monday, but I'll tell you about one. Lady who had prior back surgery. She had sciatica in her right leg, into her buttock, in her back of her thigh, and into her calf. Some back pain, but mostly the leg pain. Now, she had gone back and seen surgery, and surgery really wasn't an option. In fact, the area that had been worked on before looked pretty good. The spinal space was open. The discs above and below looked okay. There was nothing that needed surgery, and yet she still had pain. And she had moved here not long ago and had these other type of injections that we've discussed, which actually did provide her some benefit. But the problem was she was getting 3-4 weeks of relief, and then the pain would come right back. And, as safe and as effective as injections can be, the problem is that it's not something that you want to do every 3 weeks for someone. Mm-hmm. That can over time. So she really was an ideal candidate for a trial of spinal cord stimulation. So on the day of the procedure, she came in, she got some IV antibiotics, which we typically do just for prophylaxis to prevent any sort of infection. She's laying on the table on her belly, just like any other spinal injection. Numb her up real good with some lidocaine. And then basically what I do is I use a needle that is able to get access into the spinal space. And through that needle, I'm able to insert these things called leads. They look like little, actually, can I show you? I've got a little model here. Is that okay?
Sure.
I don't know if your viewers will be able to see this, but it's
we have listeners. Our listeners won't be able to see it, but we are on YouTube, so they can see it that way.
I'll describe it. It's about the size of a piece of spaghetti, okay? Mm-hmm. It's soft and flexible, and it's about the same caliber as a piece of spaghetti or fishing line, whatever you choose. This can then be inserted into the spinal space under the skin, and then that introducer needle that I use to get access and place that lead, I remove that over top of the lead, leaving those two leads in position under the skin in the back.
Then the person can go about their normal activities, I'm assuming, right? They get up off the table and then they see if it works for them or not before you go to the actual implant itself. Am I correct?
Exactly. It stimulates the spinal cord, and in some ways, the kind of one way to think about it is kind of blocks those pain signals that are traveling up the spine from the back or the buttock or the foot or wherever it may be. And then if they get good relief, they come back. Those temporary leads are removed. And at that point, there's nothing to really heal from because there's no surgery has been done yet. And if it's been successful, they have a good sense that would be a good treatment option for the long term.
So that's wonderful. I mean, my God, it's unlike surgery in that you don't get a chance to make sure if they take your gallbladder out, you're not sure until they've taken it out. There's nothing else you can do about it. But this gives you a chance to try to see if it might work. And if it does, what's the next step?
In our practice here, my focus is to do the trials, and we have surgical colleagues who will do the permanent placement.
I see.
So the permanent placement is a minor surgical procedure. It is outpatient. I mean, that should be clear to your listeners that a stimulator trial and the implant are both same-day outpatient procedures.
You come in and you go home.
Come in, you go home. For the permanent placement, it's typically done, for example, like at an ambulatory surgical center, or it could be done in the ORs as in the hospital. But, you come in at 8 a.m., you go to the OR at 9, you're out of the OR by 10, you're on the road heading home by noon. And for both of these things, like you mentioned, I think you said it well, you're up and you're doing your normal activities. You really pretty much are. Even after the permanent placement, even though it's a minor surgical procedure, those folks are walking out of the hospital that day. They're going to have some soreness. They've just had a minor surgery, of course. But as far as, one thing that's important for your listeners to understand too is, when you're going to go have a multi-level lumbar fusion, for example, you need to make sure you have really coordinated care at home with your family and getting help and all that sort of stuff. It's kind of nice with these stimulator devices that you're independent from the day of the surgery, really. You're able to use the restroom yourself and prepare your meals and things like that. Even though, for the first few days after the permanent placement, you're kind of taking it easy, but there's no point where you're incapacitated.
But you already know that it's helping you. So now you've got the permanent placement, and chances are that you're going to start to lead a normal life without having this pain that you've been experiencing for such a long period of time.
That's right.
It's good news.
Right. It is. And I actually, it's kind of an interesting part of my counseling for patients before and after, especially after the trial, when folks have a successful trial. And the national success rate's about 80% of a successful trial. In our practice, it's about 90% of folks who do a trial come back and they wish to have it implanted because they've had good relief. But I've had many conversations with people who kind of have paradoxically have a really feel down because they wish they would have pursued that sooner, or they think back over the last few years of what they couldn't do. And now
you could have been doing all those things all that time.
Right.
So you're not going to get those days back again.
Right. But, the way I kind of really have people focus is not on the past, but on the future. That's what's in the past is done, and enjoy this and make your plans and live your life. So
somebody's going to ask, now that it's been implanted, for whatever reason, and I know the percentage is very low because your success rate is very high, obviously. If it's not working for me, can it be removed?
It can be. Yeah, there are certain situations where a stimulator device might be removed. But before a stimulator device would be removed, so for example, if someone isn't getting quite as good coverage, let's say a year down the line or 2 years down the line or whatever it may be, the first step definitely would be to reprogram the stimulator. Now that's
like a tune-up for a car.
Exactly. That's done not as a surgical procedure, not as an injection. It's all done just with an external device, almost like a Bluetooth, It can be connected, and then essentially, like you said, it's like a tune-up. Maybe turn the device up or down, or there's different parameters of the stimulation that you can really modify to get better coverage. And most of the time, folks are able to get better coverage, and then they can proceed and live their life.
Well, it sounds almost like a miracle. And of course, we're going to tell our listeners and our viewers on YouTube that they're going to be able to come to our website and find out how they can access more information about this. But I'd like to get into, because I know you have limited time, you've got patients probably lined up outside your door. But in any case, let's discuss those spinal gray areas that I term gray areas. A person's diagnosed with scoliosis or myelopathy or osteoarthritis. What do these conditions mean, and how do you treat them, or can you treat them?
Yeah, that's a really good question. So I suppose with the ones specifically that you mentioned, scoliosis, for example, it's pretty common to see folks with scoliosis, which most of the time is not necessarily playing a direct role in the pain, but is part of a broader picture of arthritis and other things like that that are contributing to pain. Now, certainly there are rare instances where someone's scoliosis is so bad, and that's based off of, using imaging and angles and things like that, where a neurosurgeon would say, boy, this needs to be repaired surgically. That is a big surgery. And so whenever folks have a really bad scoliosis and they've never had a surgical consultation, that will usually be my first recommendation.
Is to see a neurosurgeon at that point.
Yeah, just to discuss it with them and see. But other than that, most of the time, scoliosis it tends to be, the cases that I see are usually what we call incidental findings. In other words, we're getting an x-ray because they've got back pain and arthritis, and lo and behold, they've got a little bit of a curve to the back, but it's, the classic, what you think of like an S-shaped curve of the back of really bad scoliosis. Most of the time it's pretty mild and usually isn't contributory to the pain. Now, you mentioned myelopathy.
Myelopathy, right.
Yeah, just for your listeners or your viewers. So that can be a pretty serious condition where myelopathy literally means basically pathology of the spinal cord itself. Now we're not talking about a pinched nerve or things like that. We're talking about actually compression of the spinal cord itself. And, that actually, there can be a diagnostic delay with that type of problem. And what I mean is folks who have a myelopathy can sometimes present with kind of vague symptoms like fatigue or instability. They stand up and they feel a little wobbly. Well, is that a little dehydrated or all these other things? So that type of problem can go undiagnosed for a while, but it can lead to problems. And that again would be a surgical issue depending on the severity of the myelopathy.
All right. So what about osteoarthritis?
Osteoarthritis, now that is a very common condition. This is not your rheumatoid arthritis or inflammatory arthritis. This is a run-of-the-mill wear and tear, age-related changes.
Your tires are wearing out on your car.
Yeah. Once you hit the age of 40, okay, that's pretty young. If you take an x-ray of somebody's spine, they're 40 years old, they're going to have signs of osteoarthritis. And again, I think what people should understand if they find out they have arthritis or they see it on their x-ray is that's not something to write home about, most of the time. It's a condition that we are all going to face and that we can all manage and live with. And the other thing that they should know is that just because somebody has worsening arthritis, let's say I see someone who's 70 years old and they've got pretty bad arthritis. If I see them 10 years from now, their arthritis will be worse. Okay, but that does not mean that their pain will be worse. It's just part of the natural aging process.
I see. And again, can that be treated with injections, for example?
It can. So it's interesting. We're in a very interesting time as far as regenerative medicine goes. Those are things like stem cell injections, platelet-rich plasma, those type of things. That's not really a part of our practice here right now, but it is a growing practice. And I think as the data comes out, it's something that we will look more and more into to maybe be involved with.
So someday you may incorporate that into your practice then.
Sure. And that may actually play a role. When you say treating osteoarthritis, there may be a role for treatments like that to potentially reverse or sort of mitigate or maybe slow some of those changes that we just don't have now. But in the meantime, we can treat things like arthritis by, for example, injecting pain medicine into the joints that have arthritis to get relief, even though we're not changing the structure of the spine or the joints or wherever we're working. If you can get good pain relief and improve function, the degree of arthritis doesn't really matter that much.
Well, that's good news. That's very good news, as a matter of fact. Now, I'm curious, this is sort of a side note, but would you find it helpful, for example, if people have continuing back pain, and even before they come to see you or during the time that they're seeing you and during the visits, do you believe in journaling where someone on a daily basis would put down when the pain occurs, how it affects them? Would that be something that's helpful to you in terms of diagnosis and treatment?
I think to some degree, yes. I think it becomes less helpful when there's, months and months and books of,
You're right. It can be overtaxing.
It can be, but and sometimes it can sort of muddy the waters a little bit. But what you bring up a good point about if people start to notice a pattern of their pain. For example, if someone comes and they have hip-related pain, in their buttock or their groin, and they say, boy, every time I get into or out of my vehicle, that really flares it up. Well, that's helpful information because that's kind of a complex movement of the hip joint that might point me more towards the joint being the problem as opposed to, let's say, referred pain from the back to that area, right? Because I wouldn't expect back necessarily to cause that.
So I think you're saying a little bit of journaling wouldn't help. In other words, write down some things so that you don't have these vague complaints, but maybe you can better pinpoint it, which will help you understand their condition.
Totally. And if there seems to be a time frame of the day where the pain seems to be worse, for example, if someone has pain mostly at nighttime or mostly in the evening when they're laying down, that tends to be more related to underlying nerve irritation as opposed to, for example, joint pain or muscle pain. Mm-hmm. So there are these kind of key history pieces that I do want to know from patients. But I also wouldn't want someone to come to me and feel like they haven't done their due diligence if they don't have, a very, very detailed outline.
They don't need to bring in a Bible, I understand. But some notes would be very helpful. No, that's good. Now, I know you need to get back to patients who have been waiting for you, and we do appreciate the time. But most of our listeners and even the viewers that we have on YouTube most of them understand the reputation of Duke. I mean, it's got a worldwide reputation as one of the best medical facilities around. But in regard to your spine and pain management center that you're part of, am I correct that there's an advantage that obviously you're a pain management specialist, but if they need more, you also are among neurosurgeons, so you can really kind of team up for a person's treatment. Am I correct?
Absolutely. That's one of the things that drew me here. It's a comprehensive neuroscience center. So we have not only neurosurgery, but we also have neurology in this same physical space. And so when I have a question about someone, or when one of the neurosurgeons has a question about someone, or they need to have someone seen pretty quickly, we are one hall across from each other, and we're corresponding with each other every single day. We're collaborating. So you're in a
collaborative situation.
Collaborating every single day. If they have somebody they've sent to me for an injection, and I do the injection, I'm messaging them and talking to them about that person so that they have a plan of what to do next. That's part of our practice, and I'm so grateful to have that.
So how difficult, this is a leading question, but obviously, I believe our listeners and viewers are going to understand you really know what you're doing. How difficult is it to get an appointment with you? We're going to have that information, how they can reach your clinic. Obviously, Sure. We're going to have that on our website, but how difficult is it to come in and see you? Do you have to wait months, or can someone, depending on do they need a referral from another physician? How does that work?
Yeah, typically what we'll do is we will have individuals send a referral, or have their primary care physician or whoever it may be send a referral to our office. And then my scheduler will get them scheduled as a new patient. And sometimes, depending on the situation and depending on where they're coming from and what type of workup they've had already, sometimes we're able to sort of combine that consult visit with a procedure visit to try and save a little bit of time and get people some relief.
That's good news.
We try and accommodate for that because, I'm married. I've got 6 kids. I understand real life. Just getting to the doctor in and of itself can be a challenge. So if we can minimize things, waits, we try and do that. I would say probably for any viewer who's going to come see me, most likely a consult would happen within the next couple weeks, from when a referral.
Wonderful. So you're not necessarily waiting for months to get in to see you. And I think that's so important, particularly if someone has chronic pain and they haven't had it treated and they really need to come to a pain management specialist such as yourself. No, I think that's good news. Well, I want to thank you very much for being with us. You've been very enlightening. I know this has been extremely helpful. And I know your time, you're squeezing us in between a number of patients because there are people waiting to see you. But I really do want to thank you and let you know how much we appreciate you spending this time with us.
I'm so glad to do it. It's my work, but it's my passion too. I love being involved in folks' lives and treating pain, and more importantly, improving their function. So I'm glad to do it. Thanks for having me.
Well, in a couple of minutes, we're going to be talking about our website and how they can access more information about you. But Dr. Gabriel Smith, I thank you so much. Appreciate it.
Have a good one. We'll see ya.
Want to discover more information about how to relieve your back pain or how to reach Dr. Gabriel Smith at Duke? All you need to do is simply visit our website, jamespolakof.com. That's James, Polakof.com. You'll also discover a variety of valuable resources on our website and other terrific Body, Mind, and Soul podcast episodes. Again, jamespolakof.com. Now back to Dr. Jim.
As most of you know, I'm a certified nutritionist. And as a result, I have a few thoughts of my own about relieving back pain. As a matter of fact, I'm going to share my 8 suggestions how to relieve back pain naturally. First of all, many of you, if you are overweight, have to consider losing weight. The extra weight places stress on your back. It creates pain. And sometimes just by losing weight alone, your back pain could be relieved. Number 2, Enjoy a daily anti-inflammatory drink. Now, there are several recipes for that. All you have to do is Google anti-inflammatory drinks. That definitely can be helpful in relieving your back pain. Also, you need to avoid prolonged standing or sitting. You need to move around. Sometimes if we sit or stand too long, the back pain comes back and aggravates itself. Also, you need to get longer, more restful sleep. That just doesn't mean 8 hours. It means 8 hours or as much possible restful sleep as you can get, because oftentimes we wake up during the night and we're not into that sleep pattern that we really need to be totally relaxed about. So that will help you. Gently stretch your joints and soft tissues with exercises such as yoga or Tai Chi. Those can be very helpful because they're not really stressful to your body. You can try mindful meditation. A peaceful mind can lead to a relaxed back. How about aqua jogging in the pool? Aqua jogging is so good because it doesn't give that impact that you get from jogging, for example, on a hard surface. And also, it doesn't really create any stress to your body. So aqua jogging could be one of the better things you can do for your back when you have pain. And you always want to keep a self-activating heat patch around. You never know when you might need it, but sometimes those heat patches can give you at least some temporary relief. Now, of course, if your back pain continues, if it becomes chronic, obviously my suggestions aren't going to be too helpful for you. That's when you need to see a pain management specialist like Dr. Gabriel Smith at Duke Raleigh. So keep that in mind as well. And Faith Michelle is correct. Visit our website, jamespolakof.com. We've got some excellent health tips for you in terms of back relief. And also there are some great podcasts that you may have missed that you might want to tune into. So I want to thank you for joining me. This is Dr. Jim Polakof. Until next time, and next time comes once a week, so look for our episodes because we've got some great surprises ahead for you.